Before the stent era, balloon angioplasty worked, well, sort of, not really in the long haul. When paired with atherectomy, it worked, well, not really well either, and really not in the long run. However, for peripheral artery disease, atherectomy has been really quite successful, and we're going to talk about a trial and about the science behind this with Dr. Mark Turco. And we're with the Chief Medical Officer of Vascular Therapies, Covidien. I remember I was there going through all of those studies. Why is atherectomy being used so well and so successfully in the peripheral arteries when for the coronaries it just wasn't really working?
That's a great question. I think the atherosclerotic process within the peripheral vessels is clearly different. It's a different beast than what interventionalists have had to deal with in the coronary circulation. And the restenosis rates and the hyperplastic responses within the superficial femoral artery are much greater than they are in the heart. So directional atherectomy seems to be working in being able to remove plaque and demonstrate good long-term patency rates that are very, very good without leaving anything behind.
In the heart, we have a layer of cells that are really, really important, and we didn't start knowing that until we started ripping them out at the seams and realizing that we lost something. What about in the peripheral arteries? Is there more room for maneuvering without taking away the gold, as it were?
So peripheral arteries are larger in general, especially above the knee, larger than coronary vessels. And when you are using directional atherectomy, you do want to be careful. You don't want to go well into layers that may ultimately cause aneurysmal development or safety issues with perforations. So we are finding, though, and clearly the evidence through our definitive LE trial seems to indicate that using directional atherectomy can be safe and effective in the peripheral vessels with very, very good long-term patency rates.
Do you think this is a growth industry, that there should be probably more of these procedures being done?
No, I think this is an added tool set to the peripheral interventionalist to be able to treat patients. And it may be and the definitive data is very interesting in that it has shown comparable results in patency between the diabetic patients and the non-diabetic patients.
Which was very impressive.
Very impressive. There are two patient populations that were studied. There was a patient population of claudicants and then a patient population of chronic limb ischemia patients. Okay. And we looked at outcomes in both of those particular patient subgroups. And the claudicants had a very high patency rate at 12 months. And as I just mentioned, what was quite interesting about that data, that the diabetic patients fared as well as the non-diabetic patients. Right. And why that's interesting is in every study that has been done, the diabetic patients fare worse. Yes. Because it's a much more complex patient population. And so we're not quite sure why, but it may be that there is something in removing the plaque that actually is the great equalizer in the diabetic versus non-diabetic patients.
So the ideal patient right now for atherectomy, peripheral artery disease, how would you describe that?
So I think it can vary. It can be calcific lesions, it can be long lesions, it can be relatively focal disease, it can be bifurcation disease, especially below the knee. It can be a varied subset of patient population. I think what is interesting is now one is that with an 800 patient trial, which is very rigorously controlled with a core lab, independent core labs, and clinical events committees. We now have one of the largest peripheral trials on directional atherectomy. So now we have some clinical evidence and really are pushing the clinical relevance of the technology. And it is another tool in addition to the drug-coated balloons that will be coming to the United States soon and clearly available outside of the United States. It's another tool to the self-expanding stents that we have and all of the other peripheral tools. So I think it's something in the armamentarium to allow the physicians to individualize their care to their patients in now a very evidence-based approach.
Well, for me, it's just kind of back to the future because I've covered this so many times through the years, and often with you, Dr. Turco, so thank you very much. And we're going to talk also in another interview regarding some of the straight data from Definitive LE. For Cardiosource Interventional News, I'm Executive Editor Rick McGuire.